بسم الله الرحمن الرحيم وبه نستعين. Assalamu alaikum everybody. Today's presentation is continuation of our last presentation, and today we'll talk about the pharmacology of heart failure. So the main goals of today's presentation, we are going to speak about the rationale of therapy of heart failure, whether it is acute heart failure, and what are the drugs that are used in acute heart failure, and then what are the drugs which are used in the chronic heart failure. So we are going to speak about the classes of drugs used in heart failure, especially in details the cardiac glycosides. We'll talk about the mechanisms involved in the action of cardiac glycosides, their indication and contraindication. We are going to speak in brief about the use of diuretics in heart failure, the renin-angiotensin system antagonist, the beta-adrenergic receptor agonist and antagonist, the vasodilators, and the phosphodiesterase inhibitors. So a revision of what we have covered last time. We have said that the heart failure is divided according to its side into left ventricular heart failure or right ventricular heart failure. Left ventricular heart failure is subclassified according to the ejection fraction into two main parts. At first, into two main types. The first type is known as systolic heart failure. In the systolic heart failure, usually there is a defect in the contraction of the myocardium, and usually the ejection fraction is less than 40%. That's why it is also known as heart failure with reduced ejection fraction, HFrEF. Heart failure with reduced ejection fraction. Usually this type of heart failure responds well to therapy of drugs, as you will see later, and usually this drug therapy will reduce both mortality and morbidity. The other type, which is resistant to drug therapy, is known as the diastolic heart failure. Diastolic heart failure. In this case, the ejection fraction, as we have said before, is normal. That's why it is known as heart failure with preserved ejection fraction. Okay, so this is the first type, which happens due to failure in the left ventricle. The second type, of course, failure in the left ventricle usually is accompanied by congestion in the pulmonary circulation or pulmonary congestion. The second type of failure is the right ventricular failure, when failure takes place in the right ventricle. In this case, the congestion will take place in the periphery. Okay, usually right ventricular failure can lead to left ventricular failure. Sometimes both sides of the heart fails. In this case, it is known as biventricular failure. Okay, so this is the heart failure, and we have defined heart failure as a decrease in the cardiac output which does not meet the body demand for oxygen and nutrient. Usually this will result in lower cardiac output, and the decrease in cardiac output will result in decrease in blood pressure at the beginning of the heart failure, and this will stimulate what's known as compensatory mechanisms. What are known as compensatory mechanisms? We have talked about that in details last presentation, but today we will just mention them in brief. So first, Compensatory mechanism is activation of the sympathetic nervous system. Sympathetic nervous system, of course, activation is through the baroreceptor reflex, and this will result in increase in the peripheral resistance and as well increase in the heart rate, and the net result will be an increased cardiac output. Therefore, at the beginning of heart failure, when there is a decrease in cardiac output, a decrease in blood pressure, this will stimulate the first compensatory mechanisms, which is the sympathetic activation, i.e. the sympathetic outflow from the central nervous system will be increased to the periphery, either to the blood vessels or the heart, and this will result in increased cardiac output. A second compensatory mechanism stimulated is the renin-angiotensin system, activation of the renin-angiotensin system. As we have said before, the renin-angiotensin system will act on angiotensin II receptors, increasing the peripheral resistance, and as well will lead to increased production of aldosterone, and aldosterone will produce fluid retention and sodium retention, and this will result in increase in preload, and at the end will increase in cardiac output. Both the sympathetic activation and the renin-angiotensin system activation will stimulate cardiac remodeling. Cardiac remodeling is a very complicated process in which many factors are involved, including sympathetic nervous system, the renin-angiotensin system, and the sodium-potassium pump. These three will lead to cardiac remodeling, and the cardiac remodeling will result in cardiac hypertrophy, and the cardiac hypertrophy will try to compensate for the decrease in cardiac output. So these are the compensatory mechanisms will compensate for the decrease in cardiac output at the beginning of the heart failure. In this case, the patient will feel no symptoms, and the patient is said to have a compensated heart failure because symptoms does not show on the patient. The patient will not feel dyspnea or tiredness or weakness or whatever. So in this case, the patient is known to have a compensated heart failure, because the heart failure and the decrease of cardiac output is compensated by activation of the sympathetic nervous system and the renin-angiotensin system. Okay, sometimes these compensatory mechanisms fails to provide enough cardiac output, and the symptoms of heart failure will start to show on the patient, and in this case the patient is said to have decompensated heart failure. Decompensated heart failure. Usually the patient may have an acute attack of heart failure in this case. Okay, so this is a revision of what we have discussed last presentation. So what are the pharmacological options available? What are the rationale behind the pharmacological drug treatment of heart failure? This depends on the type of heart failure. If it is an acute heart failure, usually acute heart failure, this is an emergency condition in which the patient should be treated in hospitals. Acute heart failure can be caused by many things, as we have said before, like for example acute myocardial infarction. Acute myocardial infarction will result in decrease in cardiac output, and the patient will enter into acute heart failure. Arrhythmia as well of different types, especially ventricular arrhythmia, can induce acute heart failure, and so on. So acute heart failure is an emergency condition, and the patient is admitted to the hospital, and usually it is treated by either increasing the force of contraction of the myocardial muscle by certain drugs, or by decreasing the cardiac load. As we have said, decreasing the cardiac load is done by decreasing the preload and decreasing the afterload. So drugs which are increase the force contraction include beta-agonists, which we have discussed when we talked about directly acting sympathomimetics. These drugs, beta-agonists, they stimulate the beta-1 receptors in the heart, and therefore they will increase the force of cardiac contraction. This includes dobutamine, and we have talked about these drugs, and dopamine. So dobutamine and dopamine, they are given in emergency to increase the contractility of the heart muscles in case of acute heart failure. If it is emergency, of course, they are given by intravenous route. Okay? Now, the second group, they are less used, but sometimes they are used when beta-agonists are not available or they are not effective, and phosphodiesterase inhibitors like milrinone, and usually these are kept as a last resource. The second mechanism are drugs which decrease the cardiac load. That means we decrease stress against the heart. We decrease the preload and we decrease the afterload. We can decrease the preload, as we have said before, by using diuretics. Diuretics will increase the excretion of sodium and water, and therefore will decrease the venous return to the heart, and they will decrease the ventricular pressure. Diuretics, in this case, we use the most effective diuretic, which are the high sealing diuretics, the most potent, اللي هم furosemide, اللي they are known as loop diuretics, including furosemide. Yet the furosemide is high sealing diuretics, which is the most potent. It is used in acute heart failure when the heart failure is strong or moderate. A second class which are used in acute heart failure as the vasodilators, like sodium nitroprusside. Sodium nitroprusside, by decreasing the peripheral resistance and increasing the venous capacitance, will decrease the preload and afterload, and they decrease the cardiac load, and therefore they will increase the performance of the heart. The last group which are used in heart failure are the natriuretic peptides, like Nisertide. Nisertide is natriuretic peptide that has a vasodilator effect, and as well it has some diuretic action. Okay, so these are the group of drugs which we are going to speak about, which are specifically used for acute heart failure, which is an emergency condition which is done in hospitals. Second are drugs which are used in chronic heart failure, and the same thing. In this case, we either increase the force of contraction of the myocardium, and this is done by cardiotonic drugs like Digitalis, and we are going to speak about Digitalis in details because this is the first place where we mention Digitalis. And by decreasing cardiac load, as we have said, by decreasing peripheral resistance and decreasing venous return to the heart. So we can decrease the venous return to the heart by diuretics, mild diuretics like thiazide diuretics. So thiazide diuretics, in this case, they are the first choice in the treatment of chronic heart failure. Other drugs including the renin-angiotensin system antagonist, RAS antagonist or renin-angiotensin system antagonist, and this includes both groups, ACE inhibitors, drugs which inhibit the enzyme angiotensin converting enzyme, and drugs which blocks the angiotensin 2 receptor like losartan and its congress. Third groups we are going to talk about are the beta blockers. Beta blockers, that are only reserved for cases of stable chronic heart failure, as we will see later, and we will know why they are used in this case. Okay, so these are generally the pharmacological options available for the treatment of acute and chronic heart failure. The first group we are going to talk about are the Digitalis, cardiac glycosides. Digitalis, which are known as cardiac glycosides. Madam, it is a glycosides, it means that they are obtained from a natural source, usually from foxglove. They are obtained from foxglove. Digitalis purpura contains many glycosides, and most important, which are contains many glycosides. The most important which are used therapeutically are digoxin and digitoxin. These two glycosides, they differ from each other in different property, and this property will determine why digoxin is used more. So if you compare digoxin with digitoxin, we can see that digoxin is less toxic than digitoxin. Why? Both of them, they have high lipid solubility. Both of them, digoxin and digitoxin, both of them, they have high lipid solubility. Once they have high lipid solubility, that means their volume of distribution will be high. They have high volume of distribution, as we have spoke about in the beginning when we talked about the pharmacokinetic. Once they have high volume of distribution, that means to reach the steady state concentration or the therapeutic concentration, it takes a long time. It takes days before we can reach the steady state therapeutic concentration. That's why in this case the digoxin is given in what's known as loading doses. The first 2 days loading doses of digoxin is given, or digitoxin. Loading doses are given. Why? To accelerate the building up of plasma concentration to reach the therapeutic concentration or steady state concentration in a shorter period of time. Instead of taking weeks to achieve the steady state concentration, it will take only few days. This is known as digitalization. Digitalization, if somebody asks you what does it mean, digitalization means that we have to give a loading dose of digoxin or digitoxin to produce a quick buildup of the plasma concentration. The second property, bioavailability. Digoxin has a high bioavailability, usually between 60 and 70, while digitoxin, it has a higher still, the bioavailability, which is above 80. The other difference between digoxin and digitoxin is the half-life time. As we can see, digoxin, it has a long half-life time, which is about 30 to 40 hours. The half is about 30 to 40 hours. Digitoxin, on the other hand, the half is about 5 times of that of digoxin, about 168 hours, i.e. digitoxin would stay in the body for a longer period of time, and therefore it should be more toxic. Digitoxin should be more toxic than digoxin. Okay? The last difference between digoxin and digitoxin, the elimination, where digoxin depends on its elimination on the renal system. 60% of digoxin is eliminated by the kidney, while 40% by hepatic metabolism. Therefore, in cases of people suffering from renal failure, digoxin dose should be reduced or should be controlled. Okay? Digitoxin, on the other hand, is opposite. It mostly depends on hepatic metabolism, and therefore its use, there is no problem in its use in people suffering from renal failure. Okay, so these are the differences between digoxin and digitoxin. Now in America, in the United States of America, digoxin only is used. Digitoxin is not used. Digitoxin is still used in some European country and Arabic country as well. But preferred drug is digoxin. Why? Because it has a lower bioavailability, it has a shorter T-half, and as well toxicity will be less. Okay? Now, so how they act? How Digitalis preparation, how digoxin act? If we can look at the myocyte, just imagine this is the myocyte, as this is the myofilaments of the cardiac muscle. On the wall of the myocyte, there is a specific pump which is known as sodium-potassium pump. The sodium-potassium pump starts to act at the end of the depolarization of the cell to extrude sodium to exchange with potassium. Sodium-potassium pump. That's why it's known as sodium-potassium pump. This is an active pump using ATP as an energy. So it is known as sodium-potassium ATPase. Sodium-potassium ATPase. So sodium-potassium ATPase is a membrane enzyme which is involved in the repolarization of the cell membrane by extrusion of sodium in place of potassium. In this case, repolarization of the membrane will take place. The membrane of the myocyte as well contains another exchanger known as sodium-calcium exchanger. Sodium-calcium exchanger. This sodium-calcium exchanger change intracellular calcium for extracellular sodium. Okay? In this case, this exchanger works only when there is high levels of sodium inside. If the sodium level inside is small, in this case the exchanger will not work. Of course, this mechanism is involved for the extrusion of calcium from the intracellular. As we have said several times, free calcium in the cytoplasm is toxic and can lead to death of the cell. The third thing that we should remember, on the membrane there is the calcium channels which are known as voltage gated calcium channels. These voltage gated calcium channels, why they are known as voltage gated? Because they open only when there is a depolarization of the membrane, when change in the polarity of the myocardial membrane. When the polarity changes, calcium channels will open, calcium will rush in, calcium inside the cytoplasm will lead to the release of more calcium from its stores in the sarcoplasmic reticulum. More calcium is released, and calcium, as we have said before, is involved in the excitation, contraction, coupling, as we have explained several times before. Okay, so when action potential arrives at the membrane, it will lead to opening of calcium channel. Once calcium enters the cell, it will lead to release of more calcium from the sarcoplasmic reticulum, which is the main store of calcium inside the cell. Calcium increase in intracellular calcium will stimulate the excitation contraction mechanisms, and the muscle will contract. Okay. Then of course calcium should be extruded either through the exchanger, but after depolarization, at the end of depolarization, calcium will exit the cell either through the sodium-calcium exchanger or through active uptake in the sarcoplasmic reticulum, where it is stored in the sarcoplasmic reticulum in specific stores. Okay. Now, so this is generally the mechanisms. So now, if we inhibit the pump, the sodium-potassium pump, this pump, they say that it is present, sodium-potassium ATPase or sodium-potassium pump. They say that it is present in multiple isoforms. The isoforms is determined by the alpha subunit, where there is alpha 1, alpha 2, and alpha 3. Three of them, they are involved in many functions. The first function, cardiac contraction, as we have explained a few minutes ago. So this is involved in cardiac contraction. Also, now it is proven that sodium-potassium ATPase is responsible for cardiac, is one mechanisms which are involved in cardiac hypertrophy, which is a bad effect. So activation sodium-potassium ATPase will increase cardiac hypertrophy, which is a bad effect, and increase in the size of the cardiac muscle. Also, it is involved in the cardiac fibrosis. So therefore, we would expect that by inhibiting the sodium-potassium ATPase, many things will happen. So drugs which inhibit the sodium-potassium ATPase, by inhibiting the sodium-potassium ATPase, like for example with digoxin and digitalis preparation, they inhibit the sodium-potassium ATPase. Once the sodium-potassium ATPase is inhibited, that means the intracellular sodium will be high, will stay high. Once the intracellular sodium will stay high, the exchanger اللي هو sodium calcium exchanger will not work. So the intracellular calcium will become high. Okay? So I repeat it again. Now, if the pump is inhibited, it will not push out sodium from inside the cell. So intracellular sodium will be increased. Once intracellular sodium will be increased, the exchanger, sodium calcium exchanger, will not work because intracellular sodium is high. We said that this exchanger works when the intracellular sodium is low. Now, if the intracellular sodium is high, the exchanger will not work. معناها calcium will stay longer in the cytoplasm. Once معناها increase in intracellular calcium. So increase in intracellular sodium will inhibit the exchanger, and this will result at the end an increase in intracellular calcium. The increase in intracellular calcium, as we have said, will increase the cardiac contraction. This is very good effect. Okay, this is one. Increase the cardiac contraction, and as well it will inhibit cardiac hypertrophy, will decrease cardiac hypertrophy, as we have said before, because we said the sodium-potassium ATPase is one of the mechanisms which are responsible for cardiac hypertrophy. If we inhibit the sodium-potassium ATPase, we inhibit the cardiac hypertrophy, which is a beneficial effect. So digitalis will increase the force of cardiac contraction and decrease the cardiac hypertrophy if it is taken for a long period of time through increasing intracellular calcium. Okay? Now, the increase in intracellular calcium is not always good. If digoxin or digitoxin is given in high toxic dose, the severe increase in high increase in intracellular calcium will result in increased automaticity of the cardiac muscles or cardiac cells. Automaticity, what does it mean? Means the cardiac muscles will, so high levels of calcium will result in increased automaticity, ability of self-depolarization of the cardiac muscle, and this will result in different types of cardiac arrhythmia. If this increase takes place in the atria, this will result in atrial tachycardia and even atrial fibrillation. If this increase in calcium takes place in the AV node, this will result in AV nodal tachycardia and even in AV node block, because as we will see inshallah next presentation, the AV node conduction is decremental. Once the rate which comes from the atria becomes higher, the conduction will becomes less. So in high calcium level, they might produce AV block, which is a kind of arrhythmia. Okay? If this increase in calcium concentration takes place in the ventricle, this will lead to different ventricular arrhythmia, including premature ventricular beats, including bigeminy. Bigeminy means that the early after depolarization, which will result in 2 beats instead of 1 beats in the time of 1 beat. This will result in different types of ventricular tachycardia and even ventricular fibrillation. Okay, so this is the first. By inhibiting the sodium-potassium pump, digitalis can increase in intracellular concentration of calcium, and this increase in intracellular calcium concentration is beneficial by increasing cardiac contraction and by delaying cardiac hypertrophy. But if the increase is too high, this will lead to different types of atrial and ventricular arrhythmia, okay, which is toxic, of course. The second effect of digoxin and digitoxin, they stimulate centrally the vagus nerve to the heart. And we have said many times before, the vagus is the parasympathetic innervation to the heart. So in this case, if the vagus is stimulated to the heart, if it takes place in the SA node, of course in SA node, the vagus is inhibitory. Parasympathetic innervation to the heart, the vagus is inhibitory on SA node. That will cause decreasing heart rate or bradycardia. The second effect, the vagus effect can decrease the conduction to the AV node, and decreasing the conduction of AV node, it has a clinical benefit, because this decrease in conduction of AV node is needed when there is atrial overexcitability. If there is an atrial overexcitability, we don't want this overexcitability to spread to reach the ventricle. So by using drugs which decrease the AV node conduction, will prevent the spread of atrial excitability to the ventricle, which is the actual pump of the heart, of course. Okay, so that's why Digitalis, it is indicated in treatment of certain types of atrial arrhythmia, and of course in treatment of heart failure. So on Digitalis, if somebody asks you how Digitalis is used in treatment of atrial arrhythmia, because it will stimulate the vagus to the AV node, decreasing conduction to the AV node, and therefore will decrease the spread of atrial overexcitability to the ventricle. So this is one of the drugs that are used in treatment of atrial fibrillation, as we will see later. Okay, now, so these are the actions of Digitalis that we should remember. Its action on the sodium-potassium pump and its action on the vagus. Both of them, they have a beneficial effect which are used therapeutically, and bad effect which will result in toxicity. So generally toxicity, what are the side effects of Digitalis? Digitalis toxicity is the most dangerous. Why? Because Digitalis, it has a small therapeutic index. The difference between a toxic dose and the therapeutic dose is a small increase in the dose can result in toxicity. That's why people treated with Digitalis preparation, they should be followed up for the plasma concentration of Digitalis. Okay, plasma level of Digitalis is increased above the therapeutic blood level. This will result in GIT toxicity, very famous, including anorexia, nausea, vomiting, and diarrhea. Immediately, the patient will suffer from nausea, vomiting, or diarrhea. In this case, the patient knows that he is suffering from toxicity, and immediately he will stop taking the Digitalis. Also, it has a CNS toxicity, which includes confusion and psychosis, which is rare. Usually, it doesn't happen too much. Like, and most important toxicity is the cardiac toxicity. As we have said, Digitalis can induce, in high dose, can induce different types of arrhythmia. As we said, can produce atrial arrhythmia and ventricular arrhythmia. This arrhythmia, usually it is increased in cases of hypokalemia. Hypokalemia, as we have said several times before, is decreasing potassium level in the blood. Why hypokalemia will increase the toxicity of Digitalis? Because potassium is a compete with Digitalis on the binding sites on the pump. Okay, potassium competes with Digitalis on the binding site of the pump. In this case, if potassium level is low, معناها there is no competition of Digitalis to the pump, and it will produce a strong effect. If potassium level is high, it will compete with Digitalis on the binding sites on the pump, and therefore will decrease the action of Digitalis. واضح الكلام؟ okay? That's why hypokalemia, in cases of diuretic uses, when we use the patient uses diuretics, like thiazide diuretics, like loop diuretics, as we have said before, they will lead to loss of potassium, they lead to hypokalemia. If the patient is suffering from hypokalemia and he's given Digitalis, the possibility of Digitalis toxicity will be increased. So it is logic to say that Digitalis toxicity is treated by potassium, because if we give potassium, potassium will compete with Digitalis on the same binding sites on the pump, and therefore will prevent the toxicity of Digitalis. So this is how we treat toxicity with Digitalis. First, we stop the drug. Of course, once the patient starts suffering from nausea, vomiting, and diarrhea, we stop the drug. We give a potassium supplement. Why potassium? Depends, oral or by injection. Why we give potassium, as we have said? Because potassium will compete with Digitalis on the binding sites on the pump, and therefore will inhibit the effect of Digitalis. We have to give antiarrhythmic drugs if the patient is suffering from cardiac arrhythmia. We have give antiarrhythmic drugs. The favorite drug in this case, antiarrhythmic drug, is phenytoin, and as well lidocaine. So in this case, we give phenytoin, which is anti-epileptic drug, or we give lidocaine, which is a local anesthetic. Why we give these two, not others? Because these drugs, they don't have effect on cardiac contractility. In severe cases of toxicity with digoxin, usually specific antibody fragments are given, which are known as FAB. Okay, so these are the major side effects. The most dangerous is the cardiac toxicity, which is different types of cardiac arrhythmia, which can be treated, as we have said, by potassium, or we give anti-arrhythmic drug. So Digitalis, it was used one time for treatment of congestive heart failure, but not anymore, although it is effective in reducing the congestion and reducing the signs and symptoms of heart failure. But there is no clinical proof that Digitalis will improve morbidity and mortality. Now it is kept only, Digitalis is kept for heart failure with atrial fibrillation. In this case, Digitalis can treat both, can treat the heart failure and can prevent the consequence of atrial fibrillation. Of course, it is one of the drugs which are used in the treatment of atrial arrhythmia, like atrial flutter or atrial fibrillation, as we have said before. Why? Because it will prevent spread of activity to the ventricles by slowing the SA node activity and inhibiting conduction through the AV node. Okay, so this is in general cardiac glycosides. A second group, which are commonly used in treatment of heart failure, are the diuretics. Diuretics, we have spoke about them in details when we talked about hypertension. Diuretics, they are first line in the treatment of acute heart failure, and in this case usually we use the high ceiling diuretics like furosemide, the most potent high ceiling diuretics, which are known as loop diuretics like furosemide. They are used in acute heart failure. Why? Because we want the maximum diuretic effect. Okay. Another type, thiazide diuretics, like hydrochlorothiazide, they are used in mild chronic heart failure. Okay. الأذر diuretics اللي هم spironolactone or aldosterone antagonist like spironolactone. This is the only diuretic which has a significant effect, long-term effect, when they are taken for a long period of time in reducing mortality in chronic failure. So all types of diuretics are used in treatment of heart failure. We use furosemide for the treatment of acute heart failure. We use the hydrochlorothiazides in the treatment of chronic heart failure, And also aldosterone antagonist like spironolactone is used especially in people who might be under treatment with Digitalis, because these are known as potassium sparing diuretics. Okay, so this is the diuretics. We spoke about this group before when we talked about anti-hypertensive. If you want to know the details of this group, you have to go to the presentation which talks about use of diuretics in treatment of hypertension. Third group, which we talked about as well before, which are the renin-angiotensin system antagonists, and this includes the two famous groups, which are the AC inhibitors like lisinopril, and lisinopril is the first line in treatment of heart failure, as it is the first line in the treatment of hypertension. Lisinopril and its congress or its like or AC inhibitors, they act by decreasing peripheral resistance, by preventing the formation of angiotensin II, and as well by preventing the aldosterone formation. When aldosterone, as we have said before, it increases aldosterone produce retention of sodium and water. Therefore, ACE inhibitors will reduce afterload and prevent retention of salt and water, and that's why they are first choice in treatment of chronic heart failure. So ACE inhibitors have been shown to reduce morbidity and mortality in chronic heart failure. Third group are the angiotensin II receptor antagonists like losartan and its congress, and these drugs block angiotensin II receptor. So ACE inhibitors, they are first line in treatment of heart failure. Why? Because they are highly tolerated and they are highly effective. They decrease in mortality and morbidity, and as well now they are cheap compared with other group of drugs. The fourth group, they are the beta-2 adrenoreceptor agonists, which produce stimulation of beta-1 receptors in the heart, and usually these are kept for the treatment of acute heart failure. So like dobutamine and dopamine, we spoke about this group when we talked about sympathomimetics. So these drugs, dobutamine and dopamine, they increase the contractility of the heart muscle, and usually they are used in acute failure, in acute heart failure. They are not used in chronic failure. Why? Because tolerance usually takes place after their use, and as well if they are used in high doses, they can produce arrhythmia. Okay, so beta-1 adrenoreceptor agonists like dobutamine and dopamine, they are only kept for the treatment of acute heart failure. Fifth group are drugs which block the adrenergic receptor, the adrenoreceptor antagonist. We have talked about this group of drugs before when we talked about antihypertensive drugs, with drugs which are used in stable chronic heart failures, including carvedilol, labetalol, and metoprolol. While drugs they are used, they said that they slow progression of chronic heart failure. Why? Because they block beta receptors in the heart, and as we have said before, by blocking beta receptors in the heart, they lead to upregulation of beta receptors, increasing the cardiac contraction. Okay. Nebivolol is a beta blocker which blocks beta receptors, and as well it has a direct vasodilator effect. It is used for treatment of hypertension, and now it is under investigation in heart failure. Okay, so beta receptors, they are only used for stable chronic heart failure. They are not used in acute. In acute heart failure, they are contraindicated, but they are used in chronic stable heart failure. Why? Because they lead to upregulation of the beta receptor, and they can improve cardiac contraction, but they are not used in acute cases of heart failure. Themselves, if they are used in toxic dose, they can cause acute heart failure. Sixth group we are going to talk about are the vasodilators vasodilators, we spoke about this before, like nitroprusside, sodium nitroprusside, like a sodium nitroprusside or nitroglycerin. And usually these drugs are kept for acute heart failure. They are given during acute severe attack of heart failure with congestion. Of course, these drugs, they produce dilatation of both arterioles and venules, decreasing the preload and afterload, relieving peripheral and pulmonary congestion. Second example is Nisertide, which is a commercial version of the plasma natriuretic peptide. And this drug, Nisertide, it acts as by vasodilatation and as well by natriuretic effect. It is given as well intravenously in acute heart failure only. Nisertide is very toxic to the kidney and therefore renal function must be monitored during treatment. Some people, they found that some people, especially African Americans, they respond well to other vasodilators like hydralazine and isosorbide dinitrate if they are given orally, or either alone or in combination. They show that these drugs, they can reduce mortality, especially in African Americans. So this is vasodilators which are effective usually in acute heart failure, and some of them, they are used in chronic heart failure, especially in African Americans. Last group, phosphodiesterase inhibitors. Phosphodiesterase inhibitors, of course, they inhibit phosphodiesterase, and the phosphodiesterase is responsible for the metabolism of cyclic AMP. That means these drugs, they will increase the intracellular cyclic AMP, and as we have said before, increasing in intracellular cyclic AMP will increase intracellular calcium, and therefore these drugs, they produce increase in cardiac contraction, increasing cardiac contraction. Most famous examples in milrinone. Well, milrinone is highly toxic, and that's why it has very limited effect. But why? Because it can cause different types of arrhythmia. Also, when it is used chronically, they found that it increases morbidity and mortality. Yet the milrinone is only kept for acute heart failure under very close medical supervision. Okay, so these are generally the pharmacological options available for treatment of heart failure. We can say in summary that acute heart failure usually is treated with beta-agonists like dobutamine and dopamine. It is treated with strong diuretics, loop diuretics, and high-ceiling diuretics like furosemide. They are treated with different vasodilators like sodium nitroprusside, and also by phosphodiesterase inhibitors like milrinone, by the natriuretic peptide, which is the Nisertide. Chronic heart failure treated by cardiac glycosides, digoxin and digitoxin, and used by the mild diuretics like thiazide diuretics, and also by the renin-angiotensin system antagonists, whether they are AC inhibitors or angiotensin II receptor antagonists, and as well beta blockers that are used in cases of stable chronic heart failure. Digitalis we talked about in details. It acts by inhibition of sodium-potassium pump, increasing the force of contraction, relieving different symptoms, but does not, as we have said, decrease mortality or morbidity. In high concentration, Digitalis is very toxic because it has a narrow therapeutic index, can cause different types of cardiac arrhythmia, including atrial and ventricular arrhythmia. Diuretics and renin-angiotensin system antagonists are first-line treatment of heart failure, and they are proven to decrease mortality and morbidity. Vasodilators, as we have said, are of value in acute and chronic heart failure. In our next presentation, inshallah, we'll talk about drug treatment of arrhythmia. By this, I came to the end of my presentation today. I would like to thank you very much for your attention. If you like my presentation, please press like. Please subscribe to my channel. I hope that you stay in peace and tranquility. God bless you and protect you. Wassalamu alaikum wa rahmatullahi wa barakatuh.